Hi, I'm Shelley Wood, the managing editor for Heartwire, and my guests here today are Dr. Bairy Merz and Dr. Roger Blumenthal. And my idea for a discussion today came from some answers I got to questions in a recent interview around patient intake questionnaires and what should be on them and what should physicians be asking about. And I certainly write about some of these things, but I'm not sure if doctors are asking about them. So I guess the first question would be whether, do most cardiologists even use patient intake questionnaires? It's a term I've heard. Does everyone use them?
Well, a lot of cardiologists don't, but Noel and I, being more in the field of preventive cardiology, and we do a lot with lifestyle and trying to motivate patients, we ask a lot more detailed questions about people's dietary and exercise habits and family history. So I think it can be very important.
I think most physicians' offices do some type of intake questionnaire, if not just to collect insurance information. But then we are regulated, or at least need eventually to have those review systems. So I think the question is, could what is probably happening in a pretty simple and not specific to cardiovascular disease questionnaire be modified to something that would really be helpful to prevention and detection of cardiovascular disease?
Because I'm assuming you've got limited time to some degree if you can have the patient with a clipboard give you a bunch of answers before you even spend time with them. Mm-hmm. So what then, let's start with you, the most important questions on your questionnaire. What are the most valuable?
We do ask specifically about family history, and we actually go over it. It is one of the major Framingham risk factors, although it's not in the Framingham score. But our new Reynolds score now does utilize it, and that can be easily accessed online. So we pay attention to family history.
Okay.
And the more relatives a person has with a family history of heart disease or maybe hypertrophic cardiomyopathy or sudden cardiac death, the more likely we are to try to target the patient in front of us for certain types of screening, and we'll try to be much more aggressive in the management of risk factors.
Some of these patients you see for years. Is this something that you give them the first time they walk into their office and never again, or do you actually give it to them again 5 years later? Right?
Well, that's a real good point. I think it's for a lot of the things like family history we go through in detail initially, but we try to make it a habit for return visits to find out if anything new has occurred with their first-degree relatives or even second-degree relatives, because it may change how aggressive we are in the management of their blood pressure or cholesterol, whether we'll be more apt to start them on aspirin or things like that. They may not qualify for existing guidelines, maybe below the threshold, but knowledge that a family member had just had sudden death or had a major heart attack would sway us to be more aggressive.
My understanding is that the clipboard comes out the first time, but you don't think of it. It's at the very back of the patient chart. You don't revisit it. So the basic questions I'm thinking I would be standard would be things like, do you smoke? Do you exercise regularly? Red meat, is that something that's on there, or I have no idea?
So we've been using a small standardized dietary questionnaire that mainly focuses on foods high in saturated fat, where we go through how many times a week that they eat them. But also we want to also find out in terms of fruits, vegetables, fiber, whole grains, try to emphasize what are the good food choices and how frequently they are getting them into their system on a daily basis too.
We very similarly do a quick fat check, but then servings of these important constituents. And this is a perfect time to be thinking about it because the AHA has just come out with their Healthy 7. Yeah. And just in thinking about this, I'll probably go back, our servings of fruits and vegetables, servings of nuts, servings of fish. Those are part of the Healthy 7, and if we anchor questionnaires to those, then you can identify gaps according to AHA standards, hand them pamphlets, brochures, or send them to the nutritionist. So it's probably a good time to be talking about this.
Sort of rework those.
With these new guidelines.
Okay. So the two ones I'd heard in these interviews I'd done recently, one was sodium. Do your intake questionnaires ask people if they check sodium content? And the other one was, do your intake questionnaires inquire about sugar-sweetened beverages? How many diet, or not diet, but I guess Coca-Colas or Sprites do you have per day? Are those things that are on your questionnaires?
Well, for us, we ask about if they add salt to their food, and is it low, moderate, or fairly high. Canned soups, how many times a week that they take, and we tend to pay more attention to that in people who have a history of hypertension or history of congestive heart failure. And then we also ask about caffeine and sodium intake, but the caffeine intake, I think, is key, because a lot of times we're talking about caffeinated beverages, but the sugar-sweetened beverages is also important, because as Noel has talked about in the past, that clearly seems to be a risk factor for people tending to gain weight in the future.
A lot of empty calories, I guess, is why they're being singled out over other less than healthy foods.
And it seems like there's a much higher risk of people developing diabetes, or at least progressive hyperglycemia, when they have a lot of those sugar-sweetened beverages. Okay,
so we've covered tons of the basics. What about some of the maybe things that are a bit out there? We were talking about one in particular that you mentioned, Roger, was one of the ones you asked about.
So for men, we ask about sexual function, and the idea that erectile dysfunction is a sign often of end organ damage, and it's a sign of subclinical atherosclerotic disease in many occasions. And discussing that maybe are one clue that the person sitting in front of us maybe is more of a secondary prevention type of individual, as opposed to a low-risk primary prevention.
So that would be a question that says, do you take any drugs for erectile dysfunction or that type of thing?
Right, and also just asking, they may not take drugs, but if they have erectile difficulties.
Okay, yeah. Because these are presumably issues that patients don't necessarily think to raise.
Correct, exactly.
Any others that should be on there? In your ideal world, if you had the perfect intake questionnaire.
Right. So there's several scales that are reasonably well validated to talk about exercise. How many times a week do you break a sweat? There are different scales that you can obtain from the literature. We've actually found more helpful is that fairly simple Duke activity status inventory. It's a 12-question. It's a single sheet. It's non-proprietary. No licenses are needed. And it's very easily scored with just adding up points. No computer is needed. It will give you a functional capacity that is well validated in men and women to be a moderate to good correlate of an exercise stress test functional capacity. And like a history of erectile dysfunction, a low functional capacity, less than 6 to 8 METs, is a high-risk indicator. And you might choose to screen that person, but you certainly would intensify therapy.
These are topics that you two are both passionate about, but some of the things you're describing to me, they may be relatively easy, but I'm not sure how many people do them.
Time-consuming.
Yeah.
So a general cardiologist or an electrophysiologist or a heart failure specialist, especially if they have a 15 minutes per patient on certain days, that's probably not the things that are going to pop into their mind first.
Yeah.
But I think the more that we can get answers to some of these questions, and many of us work with nurse practitioners, and the people who are doing some of the advising and counseling, I think these are important questions to ask our patients and try to target and try to motivate them as best we can.
Right.
And it's actually, they're already doing this 2-page review of systems. Most physicians' offices are already doing at the one-time intake, so we'll qualify it as that. But to add a second sheet that would have additional screening questions, such as erectile dysfunction and a DAISY, and then some lifestyle questions. This can be revisited at the follow-up visits by a nurse or a nurse practitioner who can have 10 minutes to do some counseling. In the state of California, our nurse practitioners can bill for counseling visits, and we find they're very effective. And again, hitting that AHA Healthy 7, trying to increase exercise goals. We didn't talk about cigarette smoking, but we ask about passive smoke exposure.
Oh, yeah.
And we ask about sleep apnea and daytime sleepiness as part of the review of systems, another risk predictor that you might act on as a physician. So it's both screening, but then it's a go-to that allied healthcare professionals in the cardiac team can then revisit and work on the lifestyle.
Another area that we both try to talk to our patients about is emotional stress and depression.
Yeah.
Because clearly those are important things to know about.
Job strain was something that we heard about at the AHA meeting recently.
Mm-hmm.
Exactly. Emotional stress, emotional strain can play a key role. And many times, we'll talk to patients and find out that they may very well be clinically depressed. That may be part of the reason why they're gaining weight, not exercising, may have gone back to smoking, and trying to ask some specific questions about their mood and stress level, and trying to pick out who's really depressed, I think is important. We may then try to contact their primary care physician or their patient's spouse or significant other and try to figure out a plan. And many times we both try to motivate people to exercise more and try to use getting back into a regular routine of exercise can certainly improve one's emotional well-being.
And are patients honest on these questionnaires, or either consciously or unconsciously? Is that something to take into account?
Well, it'll vary, I guess. Noel,
there's little incentive for them to not tell the truth. I suppose it's their own health.
The patients who we know the best, I think, tend to level with us the most. Those who may be seen as for the first or second time, we may not have gained their trust as much, and maybe they may be exaggerating what they say.
Right. I had this idea on a recent flight. I had to do one of those airport scanners where, you walk in and that thing zips around you. And I thought, wouldn't that be great if you could step into a machine, it would do a little zip, and it could tell you how many times you eat fish and how many pops you drink a week or whatever. But I guess that's down the road.
Star Trek, yes.
Yeah, futuristic. All right. Well, in the meantime, it's been lovely speaking with you both, and I appreciate your time. Thanks very much.
Thank you, Shelley.
It's my pleasure.
Thank you.